Good evening, everyone. I think as more people are joining in, we will begin. My name is Bakul Dua, and I am a clinical psychologist and head of program development at the India Mental Health Alliance. And on behalf of the India Mental Health Alliance, I'm very pleased to welcome you all to this session today. Some of you have been part of our sessions before over the past 2 years, and others may be joining us for the very first time. And I'd like to take a moment before we begin the session to share with you a little bit about the India Mental Health Alliance. The India Mental Health Alliance is a not for profit organization founded by Vasvi and Ashish Bharatram, together with organizations Amaha and Children First. I'm very proud to share that we are today a 250 plus member strong alliance. The alliance is a collective that brings together mental health organizations, cross sectoral partners, caregiver and lived experience initiatives, policymakers, funders, philanthropic organizations. And at IMHA, this collective really exists to move beyond the fragmented silos that often characterize mental health work in India, and to work collectively towards strengthening mental health care ecosystems. In all of the work that we do, lived experience or lived experience expertise is very central to our founding story and to our founding philosophy. Several of our founding members, steering council members, have themselves navigated mental health challenges or have cared for someone living with a mental health condition. And at IMHA, therefore, we hold a deep belief that lived experience is a crucial form of expertise, one that must be centered, respected, and meaningfully integrated into mental health discourse, practice, systems, policies, and structures. And it's this belief in lived experience expertise that has brought all of us together in this room today. And it's the second session in this series. Many of you joined us for the first session in December, where we explored the intersections of being a mental health professional whilst also navigating lived experience. And today, our focus shifts to, or rather broadens to, the expertise and experience of carers. Mental health work often centers, and perhaps quite understandably centers, the person living with the mental health condition, whereas much less visible are the lives that unfold alongside or perhaps in the background and beyond clinical care, which is the lives of family members and long term carers who support, accommodate, negotiate complex systems, absorb risk, and hold relationships over years and sometimes across intergenerational losses. Their labor, their expertise, their wisdom, their knowledge, and their inputs are often invisibilized and even more rarely integrated into the care journey as expertise. Today's session and the series as a whole draws inspiration from a book. I'm very proud to talk about this book today, as some of the contributors of this book are here with us. And the session today draws inspiration from the book Homecoming, published by Westland and co-authored by Nandini Murali and Neha Kirpal. Homecoming is an anthology of 11 women's stories that traces the journeys of navigating mental health, and it reflects deeply on their stories of resilience, healing, and the search for wholeness. We're going to share a link for the book, and you can access this book at a bookstore near you, online or offline. We're honored to have three experts by experience associated with this book here today. And I'd like to introduce each of them. First, we have Neha Kirpal. Neha is the co-author of Homecoming. Neha is also the co-founder of Amaha and one of the founding cohort members of the India Mental Health Alliance. Um, Neha is a lifelong carer for a parent living with schizophrenia and a survivor of sibling suicide loss, and someone who herself navigates complex PTSD. Her voice powerfully bridges personal experience, caregiving, and systemic change. We're also joined today by Dr. Kavita Arora, child and adolescent psychiatrist, co-founder of Children First, and part of IMHA's founding cohort. Dr. Arora is a contributor to Homecoming, where she has reflected extensively on growing up with a mother living with schizophrenia. And in the last session that a lot of you may have attended, she spoke very movingly about how her personal journey shaped her professional path as a psychiatrist. And finally, I'm very excited to introduce to you Radhika Piramal. Radhika is the sister of Aparna Piramal, who is one of the contributors of Homecoming. She is also the patron, founder, and champion of Pride Fund India, India's first LGBTQ philanthropic fund. And Radhika is here not only as an integral part of her sister's story, but also as someone who has reflected on her own journey and her own experience with the process of accessing care. As we prepare to begin and invite our panelists to share their stories, I just want to gently remind us all that the stories and insights that we hear today may touch us not only professionally, but also resonate with us personally. There will be references to trauma, to suicide, to loss. I hope that as we engage with and witness these stories in this space, each of us is also able to access whatever resources, internal or external, that we might need to stay grounded, present, and to listen with care, respect, and openness. Thank you so much, everyone, for being here. And I'm now going to invite our panelists. I do hope everyone's mics are muted except the panelists so that we can flow smoothly. I'd like to invite Neha Kirpal first. Neha, if we can just have some opening comments from you.
Thank you so much, Bakul, and to the entire team at the India Mental Health Alliance. This is a conversation that many of us as carers have waited and wanted to have, possibly for the entire duration of our lives. And so just to place my story for context, it really did begin 40 years ago for me, where as a 5-year-old, we started looking at what we didn't know were the symptoms of schizophrenia in the case of my mother. And so growing up all of those years was spent in a lot of confusion, a lot of often shame, a lot of sudden chaotic moments that one had to navigate, whether it was at school or at home. And I think in all of that, what we lacked as a family and also everybody around us lacked was a way of understanding this, what was happening in our day-to-day life, how to articulate and even show support, and how to access care and help. And so I think in the 1980s is when I'm talking about. The 80s and 90s was a time when schizophrenia was not really known and understood as much. And so what that meant for us was a life of unpredictability and uncertainty. And in my mother's case, actually, her paranoia drove her away for an extended period of time. And so as a family, we actually spent 10 years right through some of my schooling years and college years looking for my mother, who had left home with my younger brother, across the country. And in the course of that care journey, we found them and lost them twice over. Again, trying to find the help and care needed between my father and myself, and then bringing them back into care, and then losing them again. And then somehow 10 years later, sort of chained to a hospital bed in Nepal, found them. Today, I'm very pleased to say my mother is fully rehabilitated and is about to host the same cousins that she was hiding with in Bihar, in Motihari district. She's hosting them for a dinner party in our home in Mumbai. And so that journey has sort of gone in that direction. Adverse childhood traumas, we all understand. And looking at that, the living realities of my younger brother, a young boy whose only influence, not school, not friends, not stable family, but the only influence was a parent with psychosis, essentially spent 10 years of his life homeless and on the streets without school, and came back and to try and rehabilitate, went to Cambridge, trying to really pick up and fit in and build his life again. and dealt with multiple diagnoses along the way. I'm not so sure if we're able to pick up on comorbidities and also multiple diagnoses in the family. The whole focus becomes on the most critical, the most urgent, and especially when we're dealing with involuntary admissions and things like that. So my brother's diagnosis slipped away, and then we couldn't get practitioners to agree. And so what that meant was he tossed around between schizoaffective disorders to borderline personality disorders to treatment-resistant depression to suicidality, and we lost him in that journey. 5 years ago, he died by suicide. So that's a little bit about. Our journey as a family, and so what started as a crisis with my mother really my brother's life, 38 years of it, seemed on retrospect to be largely just collateral damage, and something that we continue to grieve and live with. I think one of the things that we realized as a family is that when it comes to navigating suicidality, everyone's experience is very different and very private. Often families are unable to talk about it, families are unable to grieve together, and people's interpretation of the problem as well as the how to actually go about trying to address it is all very different. And so I've realized that in our case, particularly when we look at a family where there are child carers and adult carers, when carers are not necessarily on the same page, and they may have a different emphasis in terms of that there's a different dynamic between my father and his wife, let's say, when he's trying to manage her psychosis, to the little child who's hiding under the dining table, to another child who might put themselves in the middle of a conflict to try and sort it out. And so all our experiences of caregiving have been very different, and they've also changed over the years. As a child, one might sort of fight or flight or freeze, and I spent a lot of my childhood playing sport as a way of dealing with my traumas. But over the years, realizing that each of us is thinking about care very differently. And so that lack of alignment often resulted in years lost for treatment and support. I think the problem with the nature of care as has been available, and I'm now not just talking in the 80s and 90s, but even up until more recently in the last 5-10 years, care is still divided in silos. It's still accessed and set up by provider possibilities, and therefore it's really left to the family to navigate who to go to, when to go, and when something doesn't work, you tend to just switch the provider, thinking that by switching the care provider, everything will take on a different trajectory. So I don't know if families like us have had the insight to really separate, are we following a certain practice or are we following a certain practitioner? And that's something that has often sort of come to my mind. The other is around decision making and realizing how hard it is to actually decide. When you hear a psychiatrist say, yes, this seems very severe, I think you should admit this person. Now, that is a statement said by a doctor on a 5-minute call. Now, the family who has a violent patient back home, and people haven't eaten in 2 days, and there is a lot of noise, and the neighbors are gathering. Maybe there are cops at the door. It's a very different lived reality to implement that one simple instruction to say, I think you should admit this person. Because the question is how. What I've realized in the last 5 years or so, working in this space with so many practitioners who are well meaning, who have a lot of expertise, is that actually these are blind spots. It's not possible for practitioners to ever fathom, without really working with people with lived experience and with caregivers, to ever fathom what are all the complexities, what are all the challenges that people go through in the course of their care journey. And so we are hoping that these sessions actually act as a bridge to help us do that. And in that course, I think just a few other things that I'd like to share, Bakul, here today for us to reflect on, maybe in the question and answers. One of those is that there often isn't an alignment between the carers as well as the person who's actually suffering, and sometimes there is no buy-in for treatment. Now we are negotiating a battle every day to try and decide who is going to win, and whether there will be a medicine that is going to be given surreptitiously in the food, or whether you're going to actually take consent and try and develop insight, or whether you're going to risk going into a hospital again, right? Now, as someone who's been a carer to a parent, to a brother, I've also been a carer for addiction, and so leaned a lot on support groups like Al-Anon as well as practitioners. I know that no one place has been able to give me all the answers. So, for myself, if I was to say, a lot of my support, a lot of my learnings, a lot of the space for grieving in terms of safe spaces that have actually held me throughout that care journey have been more in support groups, in Al Anon, in grief circles, rather than in the session with a therapist or a psychiatrist. And so I think recognizing how these need to be stitched together in some way, I think is quite key. The other thing that I've often maintained over the course of my life, and I have so many diaries filled with this. My brother also used to write diaries of notes saying, when the doctor comes, this is what I will say, this is how I will ask my father about my discharge from the inpatient. And, we realize that we have all these dialogues within ourselves. And so, in addition to a prescription, it's almost a handbook that is required of saying, you are going to be dealing with this now for the next 5, 10, 20, 50, 100 years. And how are you going to navigate it? So a handbook that actually talks about how does somebody take decisions? How does someone choose a provider? How does someone have a conversation about this? A prescription just isn't enough in a 5 minute sort of session. So I think I just wanted to sort of bring our attention to some of these really invisible parts of the journey that we navigate as family members. And I think the last piece there is really around what that looks like for us as people who are not just as a caregiver, but also living our own lives. And we have multiple identities and we have multiple responsibilities. In my own case, as an entrepreneur, as a single mother, I have a 13-year-old who has helped me de-escalate my mother's psychosis and enjoys playing football, and this is our household, right? But if you think about it, what that leaves us with by way of burnout in terms of boundaries, what is the kind of exposure that we are giving our children, and what impact that might have on them. These are all things that are our lived realities. And so as carers, I think it's often invisible, because oftentimes it's not just the joy and the satisfaction of being a carer. It's also, there's a lot of angst, there's a lot of anger, there's a lot of resentment. I spent many years thinking about how I was abandoned by my mother, and how hard it was for me to come back and be her carer. And so it really is a reversal of a relationship which is normally considered quite nurturing and a safe space for me. And so these are relationships that have been renegotiated in our context. And as we do that, in parallel, we are negotiating the risperidone and the various medications that we are looking at. So these are the complex, multifaceted living realities and often lifelong realities. Um, and so the challenge and the need to commit to treatment, to commit to care, whether it is self-care or the person with mental illnesses care, is a daily question and answer. It's not a one-time commitment. Every day we ask ourselves what we're in for and how to do this today. And I'm reminded of the one day at a time from Al-Anon, which is and from AA, which has been very helpful. So I think I'll stop there, but those are some of the reflections to leave as we get started today. Thank you, Bakul.
Thank you, Neha. I think you've drawn such a layered and complex arc of caregiving, emotionally, financially, spiritually, systemically. And I saw many people nodding in the audience as you were speaking. And the point that perhaps resonated the most with people in the audience today was when you said that as professional experts, there are things we absolutely cannot fathom, that training cannot teach us, that only and only comes from an insider insider perspective expertise. And I do hope that over the course of this session, we'll also get to hear from you how so much of your lived experience has formed the foundation of the work that you've done as an entrepreneur in mental health, and how some of your own lived realities have actually helped you figure out how spaces should be designed, how care should be coordinated, how appointment systems should be set up. So some of those things would be particularly interesting for us as we move from stories of caring to the expertise that caring holds, and how it can impact and transform systems. Uh, I'd like to move forward and invite Radhika. Radhika, I think just few opening comments from you, and to set a context for the audience about your journey.
Sure. Well, thank you so much for inviting me on this panel. It's a real honor for me to speak to so many mental health professionals. Let me situate myself in this conversation. The book Homecoming is amazing, and if you've not read it already, I really, really recommend you read it. It changed my perspective and gave me a lot of insight. My sister Aparna Piramal Raje is one of the 11 authors, and so I have two caregiving journeys that I can share. The first is I'm a carer, one of three carers to my sister Aparna, and the others have been her husband and our mother. So that care journey for me started maybe when I was 20 years old. Aparna was 22. So that is, 30 years ago. And Aparna is bipolar, and she had 10 years of what we call undiagnosis, roughly from the age of 20 to 30. Aparna is 2 years older than me. We were close sisters growing up. And as my mother and we suddenly saw her personality really shift, okay, just after undergraduate, when around she was around 21 to 23. At this time in the mid 90s, we knew we had to seek help. We knew this was not ordinary or normal behavior, but we certainly, she was having manic episodes, and she had been just fine as a child, as a teenager. So we could not understand whether it was adverse, stressful life events like, university, finding a job, maybe having a romantic breakup. It didn't fit. Okay. It didn't fit that the psychosis mania should be such a response to these kind of events. But we didn't know where to look for help at all. And I really echo, Neha, what you said about um, decision making within a family, within the carers, is often not aligned, and that can really slow down progress. So we didn't know where to look for help. And I just want to give you in this room an example of then finally the first help we found, which I will say perhaps was incomplete care, and then how we proceeded down our journey, and perhaps share some more positive examples of what I would call more complete care. So Aparna, is bipolar. The internet is not quite strong what it is today then. So we did not have a diagnosis of bipolar. We just had some mysterious, unexplained behavior that happened 3 or 4 times a year, where she would have manic episodes and we didn't know how to handle it, and we would sort of hide her away. And she was in her 20s. She wanted to get married. She wanted to have children. And so, without any expert advice from any mental health professional, she decided she did not want medication. And I think this question of whether to take medication or not, where the whole family, who are the carers in some ways or the other, really want the patient to take medication, and the patient is not cooperative, that is an area where practitioners could lean in and perhaps take the influence and the experience of carers to help their patient cooperate, rather than just trying to deal with the patient without involving the carers. But in any case, Aparna did not take medication for many years. Finally, then we went to a psychiatrist. I'm going to say this was an older gentleman in South Bombay. And he and Aparna just did not get along, because the psychiatrist really wanted to speak to Aparna's husband and not Aparna directly, let alone Aparna's sister, me. But the marriage was relatively new. Aparna's husband was relatively inexperienced in managing manic episodes compared to me, who'd been doing it for already by this time, 10 years by the time her husband showed up. And Aparna trusted me a bit more, because one of, often a patient's complaints is that their carers and their practitioners police them too much. Okay. They make them do things that they don't want to do. And the psychiatrist continuously talking to Aparna's husband rather than Aparna, both Aparna and I felt that that was crossing over a line of agency, of consent. I mean, my sister Aparna was not schizophrenic, right? She was not in this manic state all the time. She had lengthy periods where she was absolutely fine. And in that context, she is an ambitious woman with a terrific education, a strong sense of agency, a degree from Oxford and Harvard. And so she just wouldn't listen to someone unless she somewhere believed in them. And so the incomplete care is because that psychiatrist didn't ask me a single question, right? So in all this process, no therapist or psychiatrist has actually ever asked me, hey, so what do you think of Aparna's care? And do you think she's getting better or worse? Or do you think this treatment is working or not? Nobody ever asked me, which I think was a miss because, Aparna trusted my opinion on these things because I gave her more agency and respect and privacy and consent. Honestly, then at that point, my mother or her advice, this is I'm talking about 30 years ago and then 20 years ago. In good news, Aparna, has really taken charge of her health for the last 7 years. She's written a book called Chemical Khichdi, which she published in 2022. It's a, really revealing journey of how she decided to take charge. And she realized that perhaps, sister alone, husband alone, mother alone, a therapist alone or a psychiatrist alone is not going to do it. But if Aparna tries to bring it all together, then maybe she can succeed. And I think she has. She's written the book, she's married, she's got 2 teenage sons, family's doing well. So bravo to Aparna. I want to give the good example of what changed for Aparna that helped all this, because a good psychiatrist and a good therapist really did make a difference. And what did that good psychiatrist do? They gave her a certain amount of respect and autonomy without stopping to take care of her when she needed it. So it's not that you only appease the patient. Obviously, in many cases, the psychiatrist cannot. But because that psychiatrist created that trusting relationship, then Aparna was much more open to taking medicines. They still had to trial a lot of medicines before things didn't work. But it finally, when the patient started cooperating, which happened because they met a psychiatrist that they trusted. That is really when the change happened. And that psychiatrist would not dream of speaking to me or Aparna's husband without Aparna's permission. And this is something that in India, I don't know if we take consent of a patient so seriously, especially with respect to family conversations. But depending on the patient, maybe that's necessary for buy-in. Um, so, and then Aparna found a therapist who she also trusted. So that has all gone well. Um, so my questions really to the mental health community here is, why does nobody stop to ask the carer what do they think? Because oftentimes between two 30-minute appointments, which may be 2 weeks apart or 4 weeks apart, there's a whole life that's happening, right, in that family. And the carer is often the person who sort of knows what's going on. And especially if they're the carer is accompanying the patient to the appointment, why not ask them, what do they think? Especially that carer appears engaged. Because I do understand that there can be engaged carers and less engaged carers, right? And I'm sure it is very, very straightforward if we have a cooperative patient and a less engaged carer who will just go with the doctor or the professional is saying, and we see progress, that's amazing. But if that's not happening, then maybe check in with the carer. And the other thing I would just ask is, how do you as a mental health professional, therapist or psychiatrist, see your role in this care journey? Is it to alleviate acute symptoms on the spot? Because sure, that you can do in a 5, 10, 20, 30-minute conversation, and it might last a few weeks. But if your role is to collaborate with this patient and with this family, because there's always a family involved, to get that person to live kind of a full life, then I feel somewhere you have to ask the carer, because they are the person looking after the person when you are not looking after them. So I had a second, do I have time for 2, 3 more minutes? I'll give you a second example of my second caring journey. Is actually started in the last 5 years, and that's with my mother who has dementia. And in this case, now it's my sister and I, and thank God Aparna is doing so well. My sister and I are looking after my mother, and there also we have had a good experience and a bad experience. And I just want to share these two with both of you. So, especially to all the psychiatrists in the room, there will be some parallels. So my mother got dementia. Again, after COVID, my sister and I realized something is not right. Okay, something is not right. This is more than usual forgetfulness. We do an assessment test. I mean, my mother does a 3-hour assessment test. We go to a neurologist, again, an elderly man in South Bombay. And he says the following. He says, you have dementia. I mean, your mother has dementia. There's no treatment. There is no cure. You can take this pill, Adventa. It has a 1 in 4 chance of working if you've got it early enough. I don't think you have. Thanks. Bye. And that was the extent of the conversation. So there was not much in terms of either hope or follow up or grief or management or, yes, it is a terminal illness, but, how can we do stuff to treat it and manage it for maximum quality of life? And then, in fact, then I went in some distress to we looked around for a while. We couldn't find anyone. In the end, we ended up with a geriatric GP. Okay, and this geriatric GP took a much more holistic view of things. And for example, so and then actually I met Neha along this way, and then Neha guided me to very many good books, resources, online resources, um, reading materials, ways to think about it, introductions to other experts. So that helped a lot. But I just love my geriatric GP, where my mother and I now, 5 years later, the degrees has progressed. If I walk into the room, she will just instinctively just see how is my mother, but she will also check in on me. So, for example, once I walked in and she said, "What's wrong?" She started with me. She's like, "What's wrong? Tell me what's going on." And then she suggested, "Okay, she's like, you've got caregiver fatigue. You look totally burnt out. I suggest you meet a therapist." And I'm surprised you haven't already in your life. And so then my therapy journey started, which has helped. So these are my examples. I hope that they are helpful in terms of what is also what I would call incomplete, or I mean, I can go further and say grossly inadequate care, versus, something a bit more well-rounded and holistic, and that helps the carer and the client or patient. Thank you.
Thank you, Radhika. On a side note, we need to talk about elderly men in South Bombay and what they're doing wrong. But thank you so much, actually, for really very detailing for us what inadequate, absent care looks like, and what balanced, humane care looks like, and that it may not be anchored to a profession. It didn't come for you from the psychiatrist that you saw, but perhaps from a GP, a family doctor, as we call them, that really their sensibility is to be able to weave the entire family together, and address the entire family's kind of concerns. But I think as we move along, I'd also like to hear more from you, and I'll come back to you about how, despite all the privilege that you may have carried, and I know you've spoken about privilege several times, how, despite the privilege, there were certain things the privilege allowed and enabled, but it still didn't ensure care for 10 long years. And even after you accessed care, it was far from adequate. So I'd also come back to this whole idea of privilege at some point. Over now to Kavita, our final contributor and panelist for today.
Thank you. I think I'm still absorbing what Neha and Radhika have spoken about, and there's so many parallels. And I'm sure people in the audience feel the same way. But before I speak as a psychiatrist today I would want to speak as a daughter first. And so for context, I grew up with a mother who lived with schizophrenia. But for most of my childhood, I did not know that. I didn't know that it was an illness. I didn't know that help existed. I didn't know that there was something wrong with her in terms of an illness. All I knew was, things were unpredictable. There was a lot of fear. Things were sometimes not just frightening, but very confusing. And I knew that no one explained it to me. But, I do believe, I work with children now, that children notice everything. And it was obvious that there was fear in the house. There was confusion in the house. There were moments where my mother sort of was present yet absent. She would disappear. She was unreachable while being there. And yet, me and my brother, we did not have any language for what we were sensing or going through. There was no framework. There was no forum to take this confusion and grief and loss. And I believe that when this kind of distress has no name, then it turns inwards. and it doesn't disappear really. So either it sits inside us, and for children, often it becomes self-blame, it becomes shame, it can become hypervigilance. So I would enter every day after school, not knowing whom I would meet at home, which mother, which person I would meet at home. So I was always sort of vigilant and really in arousal mode when I entered home every day. And a lot of it also became about silence because there is no forum. So where do you go? And those parts of us, as I grew older, I think I naturally stepped into this caregiver slash carer role without wanting to, without opting for it, because I think that's what happens. You are, it's not as if you have an option. You step into the role and you love the person and you feel responsible for them. But there is also mixed feelings. So I think there is, I felt a lot of love, a lot of responsibility, a lot of hate, a lot of anger, and a constant sense of there's no one asking me how I'm carrying it. So oftentimes it was about her, it was about the illness. And even when I was older and I became a psychiatrist and I would accompany her for her treatment, it was always subtly about we will treat the patient, you please manage yourself. And structurally, the carers are invisible. And you adopt that. So I even, as a psychiatrist, I adopted that position of being invisible. But I've often wondered what that did. So despite having the privilege of being a fellow psychiatrist, going to a psychiatrist or a neurologist with my mother, um, it still would, it wouldn't be obvious that my word would be trusted about her. So I could bring up something, but either it was dismissed as being over involved or as you're too anxious, or sometimes, with a bit of a frown and saying, yeah, that's all right. But there was hardly ever a sense of curiosity about what this might mean and could I help with early detection of something and not be seen as interfering. And often I see that now in practice when I look from this point of view. How do we view carers or the person who's coming with us? Are they only a resource to give us the history? Oftentimes that's what we see. We don't see them as whole human beings. But on the other hand, there's a lot of emotionality sometimes involved in this. Oh, that mother is coming, that father is coming. And there's a very quick sort of what are they bringing into the room is not their whole personhood, but how they usually have been about the carer. So, and whether they are an interference with the clinical narrative. And so I think I have often wondered what that could do on the flip side for the carer. So in my case, over a period of time, I lost trust that my word was important where my mother was concerned. So it gets replaced by silence, which means that if I am an ally and I could pick up things, even if I didn't have the vocabulary, the care suffers. Because I know that the practitioner is not accessible to these vague, non vocabulary sort of sentences of, I know something's wrong, but I don't know what. But I definitely know something's off. And I remember saying this to so many of the neurologists who, for over a year, I visited 6, 7 of them. And then everybody just said it's schizophrenia. This is what is happening. That is what is happening. And I was like, no, this is not. I don't know what it is, but this is not my mom. At that time, I was in UK. I just flew her to Delhi, and we did an MRI, and there was an enormous meningioma, a brain tumor sitting there. It was 5 centimeters big. And the neurologist told us if you'd waited for another few days, she wouldn't have survived. And everybody attributed her symptoms to schizophrenia because that was her history. So this is also about then figuring out, I also wasn't sure what was off. I didn't have the vocabulary. I wasn't a neurologist. So I've often wondered now what the strength of a carer is. And like Radhika was saying, we are really wanting to help as carers. We know a lot more, but we may not have the vocabulary that is part of the clinical narrative, but there is a lot we do know. And if we are not included, then in my case, what happened was that trust fractured with the system because I felt that despite being within the system with other hats, the system did not have the wherewithal, or the space did not have the wherewithal to hold the complexity with which I arrived. And if it can't hold complexity, then I might as well shut up. And this part, nobody's going to help me with. So this aloneness that comes out of, okay, then I will only use the care and the practice for this much. आप बस दवाई बता दो, you just tell me about the medication. The rest I will have to manage, and I will go elsewhere to manage it. And each of these times, this fragmentation of care that happened, I mean, when I was a child, when I was a little bit more of an adult, and then I became a psychiatrist, it still was difficult because there is such fragmentation of care, no singular person who's able to guide you and witness on that journey. So today, I think I'm not trying to critique individuals or systems, because I think what I've also understood over the years with my colleagues and everyone is that most people that I see in psychology, psychiatry are well-meaning. They're very well-intentioned. They're committed professionals who have actually come into the profession to help and to be of service. And most of the people I have worked with have a very high regard for ethics for their profession. So I often wonder then what might shift in awareness and in recovery, both for patients and for their families, if we truly took the caregiver lens into account. And why is it that professionals are not doing that? Why is it that the illness becomes the primary factor, but not relationships, the unspoken knowledge, and beyond the symptoms? And I wonder if that could be a wondering and a question that we could reflect on with the audience as well. Thank you. Thank you for letting us voice our stories.
Thank you, Kavita. Kavita, as you were speaking, I remembered that when I was doing my clinical training, one of the commonest phrases I would encounter in medical files was part of the description of the person, and in the end it said caregiver over involved plus. Right? Over involved caregiver was a descriptor, and it was code between professionals to say when you encounter the caregiver, they will need to be managed, they will need to be kept out of the process. And no one stopped to question what over involvement means. Over, according to whom? What is the optimum level of involvement? How can one possibly titrate involvement in the life of a person? Uh, when you're so chronically enmeshed in their waking, sleeping, uh, and over involved was a term that everybody used to describe caregivers who annoyed them because they asked questions, or because they were too demanding, or maybe perhaps they were too desperate, or perhaps their needs were so uncontained that the 10-minute OPD, or even the 50-minute hour of psychotherapy could not contain it. And so boundaries was the intervention that us extremely wise clinicians would come up with. And
And I wondered what the name was for the disengaged ones.
oh
What
yeah,
the
absolutely.
judgment was that this is not enough involvement. So
Absolutely.
I have often wondered what is the perfect level of involvement that
Titrated.
it needs to have for the
Just right. The
just right
Goldilocks caregiver.
all the time.
And
And really,
Bakul, now that you've got our backs up with that, and you saw Radhika and me both cringe, I think I'd just like to say that boundaries should be thought about once there is a relationship. And so that's the key thing, that we are already establishing boundaries, but we haven't yet made the relationship perhaps. But that's just my reaction to the word over-involved carer. Back to you, Bakul.
Yeah, thank you. I think as each of you have shared your personal lived journeys, I want to now zoom out a little bit and connect the audience with some universal realities of caring. And one of the first things I want to start off with, Neha, I want to invite you, is I know that you've often debated about the use of the word caregiving versus caring. Today we are using the word carer rather than caregiver. And it's not just about terminology, right? The subtext is about the unseen complexity of caring. And what comes up for you when you think about this unseen emotional arc of the complex emotional arc of caring versus caregiving? What feels invisible, what feels visible? What would you like the audience really to know, that something that is invisible perhaps to most people?
I think I have a very complicated relationship with both of those words, as also with my journey of caring/caregiving. Because I think when I think about it in a zoomed out sort of way, there are some feelings that come up that I hold as a child, and some that I'm holding today as an adult, and some that I'm holding today as being involved with running and providing mental health services and building the alliance and working with all of you mental health professionals. So it's also been a journey, Bakul, of being very angry, upset, let down, disappointed, judging the practice and providers, really looking at fault finding, and so there's been a lot of that in the early years, to a recognition that actually people don't know what they don't know, and they may have good intentions, but there is also a conditioning, whether it's a biomedical conditioning or it's a conditioning of a certain protocol and process, or it's a conditioning to say, for example, now you are admitted in Nimhan, so we will not listen to your psychiatrist sitting in Delhi, whatever it might be. I think these gaps, what we call care gaps, are actually complete breakdowns. For a family, that one care gap could be the end of a life. And so, I think just putting these words that we use as care gaps sort of into perspective here, and say that it's really important to establish that relationship of trust. So it takes a long time for carers to even trust themselves, right? And you're constantly second guessing yourself. You're constantly wondering whether you're doing enough or you're doing too much, right? Whether you're being just to yourself or you're being just to the other person who you are trying to take care of. And so this is a battle that we have, or at least I have had with myself all along. And then my inner child has that battle with my adult version, and vice versa, right? So there's all of this going on, and I haven't even moved to a second person yet. Then there are the family dynamics and how each of us plays our roles as carers, and again, the felt experience is very different, and the responsibilities for some people, I mean, in the case of my father, for instance, as he moved on, had started his own life, was already divorced from my mother. Um, it was a it was a moral obligation that he felt towards the mother of his children, that he wanted to support her treatment, right? But which is very different from my journey as a daughter. Similarly, for my brother, my father's sense of responsibility was as a provider, but as also the person who was controlling the money and making the financial decisions. And therefore, there was a difference in the say that people have. And so, while I might be coming from some experience within the mental health space and talking about a certain care and treatment plan, but my father's relationship is different, because he's coming at it intuitively, but he's also coming at it as the one deciding to pay for stuff, right? So all these dynamics actually really sort of play a role. So to me, I think there are some politics around the way we internalize these identities also within our own selves as caregivers, and it creates a certain power dynamic. I've often, my mother and I have had very frank chats about her journey with schizophrenia. And especially after the book is the first time that we spoke about the last 30 years. We spoke about what it feels like to have the condition, what she remembers, how she feels about what she remembers. and her regrets, perhaps, or her reflections on relationships. These are all conversations that open up for us. They've opened up 40 years later. And for many families, they will never have the chance to have these conversations. But I think these relationships are complex, is what I'm saying. And so for that reason, the one nudge is that at the very least, we offer the spirit of partnership. Because I think we may call them over, what was the word, over committed, over involved carers, but actually here are people who are in some cases, might I even say, know better what exactly might be the need in that moment, and how exactly to try and do step one before step two and de-escalate and so on. So I think there are things that carers know, and people with mental illness who are dealing with it know and have as insights that professionals will not. And it's really about the coming together. I go back to when we started the journey with Amaha 5 years ago, and looked at saying, what should we call this organization that is with the spirit of partnership, with the spirit of listening and learning and co-creating the pathway, the care journey in its entirety. And we really came up with this idea of being your mental health partner, so that at least the intent of a lifelong, ongoing, unconditional partnership, where there are no gaps, hopefully, and over a period of time, we're able to stitch it together. And I remember using the words very early on to say we are the safety net and the trampoline, and that's how we need to think about it. People shouldn't fall between the cracks, and yet we should be able to help people thrive and make the most of their caring journey, as well as their journey dealing with mental illness.
Neha, if you also want to share with the audience the experiences you've had with caregiver communities rallying together on WhatsApp as resources for each other, and how that's something that clinical care sometimes often doesn't even come close to because of all the gaps that exist.
Yeah, over the years, particularly in the last few years, if I look at the wonderful work that Vijay is here on this call, what Vijay is doing with his organization, Amrit Bakshi ji is doing with the Mission Group, Avani Shukla with Warriors Connect, there are so many carer movements, and I made a reference to Al-Anon, really sitting in a circle where people are sharing all of their traumas, their brokenness, their challenges, their difficulties, and what are the hacks, what are the quick fixes, what is the jugaad, but also what are thoughtful learnings, what are the painful realizations that they've had. Often, a lot of it is about acceptance, and a lot of it, which is not really talked about, is about surrender, and is about accepting what you cannot have control over. And I go right back to the serenity prayer, whether it is a work meeting or whether it is a friends group discussion or whatever. I'm constantly saying that the serenity prayer has been the biggest gift to my life. I have applied it in every area of my life. It's kept me relatively sane, and really, I think that to me has been a big takeaway, because the kind of validation, the kind of acknowledgement, the kind of strength you get. And this is the journey of homecoming. 11 women coming together, bearing their hearts out, talking about every trauma they've been through. It's right there, right? It's raw, it's real, it's honest, it's relatable, and it's complicated. And yet we're standing there smiling on stage, holding up this book and saying, this is our gift to anyone who wants to go and explore the stories of their own lives, and how they may want to relook at it in a way. So these are opportunities, and I feel like every time you're in a group, in a support group, or in a group of like on this WhatsApp group, there are 500-600 families every day, all day. We have a 5 minute, not even a 2 minute response time, whether somebody's trying to find a psychiatrist in Ludhiana, or somebody's trying to figure out what to do if haloperidol went wrong, or somebody's looking for a therapist, or somebody's wanting to get a second, third opinion from a carer about what their psychiatrist said. Or oftentimes I get calls to say, can I please talk to you before I talk to a psychiatrist? Because I need to figure out first, and there is a sense of trust, because you know that the other person really truly knows. And Kavita talked about silence. I think just by being in those rooms, you know that there is a shared felt experience. This person will intuitively understand my needs, my struggles, and my challenges, therefore my dilemmas, and will be able to help me get to a decision, even if it is not a decision that is rosy and everything's going to be fine, even if it's a decision to step away, and let things take their course. I think those are very difficult life decisions to get to. We know, for example, in the case of my younger brother, he suffered for a long time and he continued to be suicidal. And towards the end, we had admitted him for 5 months into an inpatient center. We knew that the treatment was not working. It was literally just keeping him alive. And the journey from there to realizing actually what he would want as the outcome of his care journey after all the doctors and care providers and carers had a go at it. So I think these are all choices that one needs to respect. Often it's painful and it's hard, but again, the support groups, people who have been there and understand it, if there could be a bridge, my dream is if these groups and groups like this, mental health professionals, would find common spaces to talk to each other, and there will be so much learning there, and so many care gaps and breaking points will be bridged just by bringing people together, literally. And so this is what my hope is with Homecoming and also with the work that we're doing at IMHA.
Thanks, Neha. Uh, Radhika, I want to bring you in here when we speak about the care journey, and uh, I want to touch upon just this idea of privilege and the assumption that resources will guarantee you quality care or will guarantee you access. And your experience was a lot more layered than that simple uh, idea. What was the role that your privilege played in enabling care, and where were points where you felt that it just didn't matter?
Yeah, thank you. It certainly helped. I mean, financially, it makes a huge difference in the ability to seek help. And if the help is not right, to then go to a second provider or a third provider without having financial stress about what is all this trial and error costing us as a family. So I don't want to diminish the importance of privilege in any way at all. It really is important. And the second thing I would say that the privilege gave both my sister and I, despite her, being bipolar and at times being extremely vulnerable, but at other times being her full self, just absolutely confident working woman, is the privilege gave her that confidence and that boldness to ask and insist for better outcomes for herself. Okay, she had that self-belief that, you know what, if my doctor talks to my husband behind my back, that's not okay for me. And I just wonder, even in this call, how many of us as Indian women feel that sense of authority? And I think that comes from privilege, self-authority, self-agency. Because in our family that was not okay. That's not how our mother brought us up, with to have a fair amount of self-agency, dignity, choices, etc. So that's what the privilege gives. I think what it doesn't give is, just all the emotional, rich people feel pain and anger and anguish the same way as poor people or middle class people. Um, so it doesn't take away from any of the feelings. Money does not insulate from feelings, I'm afraid. Um, so, and the outcomes really dependent on trust and care, and the actual journey of the illness, and then, medical interventions and all of that. So those outcomes, they can be good, they can be bad. So yeah, I think privilege helps, and it can help sustain also over a long period of time. Um, but yeah, it cannot protect beyond a point.
Yeah. And when we talk of privilege, we always speak of the intersections of identity, that you may be privileged on some identity locations and perhaps on the margins on some other identity locations, which also brings me to how you negotiating or navigating with your own sexual identity. How was that part of the journey? How did that complicate things, or what was that like?
Yeah, so just for the benefit of the audience, I think some context would be helpful. I think this is a very rare panel where, without it being the topic of the panel, two of the three panelists are queer women. I identify as lesbian. I came out to, I guess, myself when I was 14 years old in the mid 90s. at that time, it was so taboo, both mental health as well as being a lesbian, that it didn't even occur to me that I could or should seek help for this in terms of talking to anybody. Like, that did not seem a safe option at all. So I just sort of carried on. I, in fact, told my mother and my sister, and they gave a lot of unconditional support and love, which I expected from them. So I think the three of us have really taken each other through life, and we are grateful for each other. But it never occurred to me that I could talk to a therapist. And I fear that that is still the situation for many people today. I just want to put that out there as an invitation to all the therapists and psychiatrists in this room, that I wonder if you realize how many teenagers in India would still feel that there's no way they could discuss sexuality with a parent, or if they are being bullied in school or excluded or in any way. I had a lot of bad language around me. Like, people would, like, fag was a common word then as an insult, right? So I would constantly be in friends groups, especially my brother's friends, cousin brother's friends, who would say, "Don't be a fag, you fucking faggot," all this shit. Like, and I'm like, oh, what about me? Um, so anyway, I'm not sure I'm answering your question. I think in the long run, being a lesbian has made me a better person, more self-aware, more knowledgeable, more empathetic, and very much concerned with my agency and my rights. So I will say that has actually not been a disadvantage in the long run, but it's taken some time to get there. And I do invite any people on, or any professionals on this call, if you have questions about how to deal with a gay, lesbian, transgender, or bisexual patient, please ask. Kavita and I are here right now. It's a rare opportunity.
Thanks, Radhika. Kavita, the same question for you.
So I think mm, it's how all these intersectionalities, not just one or two parts of our identity, we carry around and yet we do not show in all our contexts. So I'll start from the psychiatry context to say that in my experience, both as a psychiatrist and then my attempt to be more like a psychotherapist and my attempt to be a supervisor, in all these, I find that most of us seem to quietly hold our competence for the outside world, whereas inside we are hugely unresolved. Our profession does not allow for the intersection of any unresolved part of ourselves to be out there as part of our, or as bringing into the room with the work. So whether it was my queerness or it was my status as my mother's carer, neither one of these were to be brought in because they would cloud objectivity. Yeah, so these subtle signs right from the beginning are in this profession, bringing your whole self in, especially these two intersections, is going to emotionally cloud your judgment. And objectivity and intuition are mutually exclusive. And objectivity, professionalism, and lived experience are mutually exclusive. So don't bring one to the other. So if you're queer, and I did the path of bringing it to the public, and I cannot tell you how many people dropped out. They called up children first and said, "We cannot send our children to someone who lives in sin." End of story. So the intersections with that, the intersections with, for example, my mother, who did not, at her age, have the capacity to understand, unfortunately, what this meant. And however much I've had these conversations with her, my mother's passed now, it's been 10 years this year, she just could not figure out what this relationship could mean or what this orientation could mean. And there was nobody that I could take her to because, well, I was a psychiatrist myself. If I can't explain to her, then who will? Secondly, with somebody who has schizophrenia and then a brain tumor, how does one explain? Whom do I go to as a specialist who will sit down and explain to her what sexual orientation is? Who exists? What kind of a person exists who would sit down and do that alongside making a relationship with this person who has schizophrenia and who may say a lot of different things? So in many ways, this does not exist. This is not part of care. So having said that, I think one other thing, I think Dr. Sanjay is on this call as well, who is the Association of Transgender Health in India. One of the things that we are also trying to sort of help everyone realize is this: till the time the Section 377 was actually brought down, this was all criminal. So I have grown up, and Radhika has grown up at a time where if you spoke about it, you could be put in jail. So 2018 is not very far back. If I'm 50, then till 43 years of age, being a lesbian was criminal. So how does one talk about it? How does one bring it into anything? Forget about speaking to your parents. So it's only now that the generation that is probably born after the decriminalization and is now growing up will probably not see it as, okay, I'll be in jail if I talk about it. But we're all living with these histories and these baggages, and going to a psychiatrist in itself, for many people who are different in their sexual orientation or gender identity, is in itself, thinking about it is traumatic. And I don't think that as mental health professionals, often we are able to hold that history and emotional baggage in our rooms with any kind of understanding when a person walks in. I'm going to stop here because I think it's a full 2 hour thing, and I can see that Dr. Sanjay has put on his video, and maybe.
No, and I think it's a topic in its own right. I don't only want to superficially in tokenistic way just touch on it, but to say that caring is not a monolithic experience. It is influenced and shaped by multiple identities that we and our families bring into our role in the world. And we have about 45 minutes left for this session today, and most of it remaining we want to use with the audience interacting with the three of you. But before I open this space up to the audience, I'd like a few concluding comments from each of you, specifically perhaps telling the audience or reflecting on this whole idea of caring or lived experience as expertise, and what is it that care practitioners can take away on how care can be collaborative with lived experience, on how lived experience can inform care, and what are there some concrete takeaways that you have for people today? I know, Neha, much of your work in the last few years has been about using your experience and bridging it to become expertise in the world of mental health. And would you like to start about what are some things that people still don't know or still don't see about lived experience, including caring, as expertise?
Yeah, thanks for that, Bakul. I think the first we have to recognize the expertise that we are holding within ourselves and recognize it as expertise, right? So some of it comes intuitively, some of it is by experience, some of it we take for granted. I don't think there are too many carers who will sort of say, I'm an expert, or I'm a lived experience expert, or I'm a caregiving expert. But I think it's really about recognizing that there is expertise here which is unmatched and unavailable in anybody else's context but yours. So the first realization that I have had, and again, as I mentioned, that as carers and as people whose lives have been completely torn apart across 2 generations with severe mental illness, it took us a long time, personally also as a family, to start thinking about mental health professionals as possible collaborators or partners, right? So oftentimes families go through a journey of really seeing being on the other side, and seeing this as a real sort of seeing mental health professionals as uncooperative or as perpetrators or as people who are not being inclusive, etc., to then coming to a place of realizing that actually there can be some coming together, to realizing what the gaps are in the training and in the clinical expertise and in the biomedical model, how just certain things are not explained, and how everything does needs to be explained and classified and put a label on, and therefore anything that is more than one thing at a time, multiple diagnosis or complexities or physical and mental health challenges, etc., becomes something that we don't know how to deal with, and then the family will secretly go to an Ayurvedic doctor or a indigenous practices doctor alongside. Disclosures are then not made, etc. So I think the first thing is to recognize that there is expertise in the lived experience. And it's a combination of our experience, of our knowledge, of our insights, in how to respond, in how to predict and preempt, because you can see the patterns, you can see what is coming. I mean, I know just by looking into the eyes of my mother, I know how far we are off from a complete psychotic breakdown. And so it's a countdown, and it's a race about how much one is medicated. So right? And these are things that you find very hard to articulate, because how do you tell someone, I just know, I've seen it for my entire life, and I know when, she may be present, but she has sort of left the building, right? So how do you actually, these intangible subjective things, to be able to try and bring them into some sort of structured framework so that they can be accessed as knowledge, much like clinicians are accessing other bits of knowledge. And this is a lot of what IMHA is trying to do. A lot of our work at Amaha Children First is to say, can we build systems where this is something that we are trying to center, where we are constantly listening, we're constantly saying, okay, yes, we can take people on our app, but people are actually on WhatsApp, and people need things at 2 in the morning, not in 2 in the afternoon. And so these are the things that we need to be listening and responding to. So it's really about first recognizing the expertise, then recognizing that the expertise does not exist with the people that you are putting in a position of responsibility. Oftentimes, we go to a psychiatrist and psychologist after 5 years or 10 years and then say, now fix me, right? And then we get impatient saying, your clock has started and you haven't delivered, right? And this really can be a life or death situation as well. So to recognize that there are limitations within science, there are limitations within providers and within certain practices. And so no one really has a silver bullet here. I think that is also really important. So to recognize where expertise does not exist is also very important. And then to be able to say, okay, what does the Holy Grail look like then? How do we bring these perspectives together? And for that, I think everyone at the table needs to see that there is value and there is equal value by everyone else at the table. And once we are doing that and sitting around the same table with an equal say and an equal ability to contribute and influence the outcome, influence the way forward, then I think we have a partnership that emerges, and expertise can then determine everything. I mean, just in terms of, if I was to look at the 5-year journey I've had in this space today, in Amaha, we work with 250 plus mental health professionals, psychiatrists, psychologists. We've built our first hospital. We've got multiple centers. We do online work in 18 languages across 600 cities, 40,000 clients at a time. At Children First, for the youngest children, families who are traveling in from different cities to be able to get care within Delhi, and a specialist team that focuses on a range of childhood developmental disorders as well as childhood mental health needs and adverse childhood traumas. Each of these families, to be able to work with them, to be able to listen in, recognize their cultural context, recognize their social living realities, recognize the school, college, workplace influences, and factoring all of that in is really what that holistic care planning needs to be all about. And so I think that's really the nudge, that how do we bring that together? And looking at building a hospital, or looking at how an ambulance, how you can safely bring in a client who is involuntary for admission, all the way from that to medication management, to buy-in for treatment, to consistency and follow through, and rehabilitation needs. All of these have to be looked at with this lens. And so, as you can tell, I'm a big believer in lived experience expertise, and all these 11 women have very generously, I feel like, added to and begun a movement of mainstreaming and mainstaging this whole idea of lived experience expertise. So the chapters actually are not just stories and anecdotes, they are actually saying what in your mind has been the most important factor that has been a make or break. What have been the care gaps? What are the learnings and reflections that you would like to leave behind for mental health professionals? What would you like to say to people in terms of accessing informal care, in terms of support groups? How do you handle severity and suicidality and sort of traumas and crisis management? But also, how do you handle how have these 11 women handled the adversities over a longish period, 2-3 decades of time? The approaches change in all of that. And so recognizing this whole thing as expertise really is the long and short of it, and is my submission to the group here today.
Thank you, Neha. Kavita, as I invite you to share your concluding takeaways for the audience, I also want to highlight that Kavita, at the moment, along with the team at IMHA, is at the forefront of developing a one of its kind program for psychiatrists. And one of the core elements of that program is partnering with lived experience expertise, collaborative care. And Kavita, if you just want to share a little bit about that philosophy and uh, how it's come from your own lived journey.
Sure, sure. Thank you. Thank you. Yeah, so I think with the book, I'll start with the book and then go on to this program because I think it's all in context with each other and my own life as well, along with IMHA. Um, I think my journey would have been less lonely, and my mother's journey would have been less lonely if there was the possibility of alliances and partnerships. If there was the possibility that somebody was listening and willing to say, you don't need to hold it alone, but I also don't need to hold it alone. And that there are partnerships around, and we all have different kinds of expertise and strengths which all exist within the system. Can we recognize them? Can we accord the same sort of gravitas and credibility to each one of these dimensions of expertise, rather than saying that everything is going to be taken care of by a mental health professional? Because now, on the other side, I know that's impossible. It makes the mental health professional feel very lonely and and overly this thing. So I wonder then that, so it's the nudge often is not about then saying, I'm going to a psychiatrist, they need to fix me. So the nudge towards all the mental health practitioners today is not that you now have to fix all the entire family's trauma. You have to abandon your clinical boundaries and become, therapist to the caregivers. That's not the nudge. So then what is it that is possible? So all these existing strengths, if we could actually bring them together and we listen to each other with a sense of respect for the non-clinical knowledge also, we are able to acknowledge the personhood and the emotional histories and the family itself, and we are able to create space for dialogue, not compliance. I will treat you and you will comply is not going to work. But if there is space for dialogue, and therefore an alliance and partnership between all the concerned people, because there is different kind of expertise which exists in the lived experience person. They are the ones who actually hold that expertise. Nobody else does. Now, if that is my learning, so to speak, from my life, and this is the learning that a lot of other people have had as well, then how do we actually bring it together and make sure nobody's feeling alone? Neither the carer nor the client or the person with the lived experience or illness, nor the practitioner, because each one of them can actually come together. So that is the basis of saying, okay, so then what do we do to bring this together? We should have then people with lived experience and carers have the same kind of respect and footing inside that room. The person with lived experience should also have the same kind of footing in that room. The expertise may be different. The psychiatrist has a different kind of structured knowledge. And if we could bring this together, who would bring it together, and how do we help develop this kind of a program and dialogue and reflection amongst current practitioners who are actually looking to say, I don't want to do this alone. I really wish I had a space and a forum where this could be done together and we could learn from each other. And that is what the early career psychiatrist or Manthan is going to be about. And that is what we are trying to develop. And hopefully, we are launching in a couple of months. And I'd invite anybody who's a psychiatrist to please look out for that. The hope is to actually co-create that program and make lived experience expertise as one of the mainstays, but also psychology and psychologists and therapists and people who've actually run systems also to contribute. So it is cross-sectoral in the way that we are going to do it. And it is hopefully also going to look at many kinds of identities and orientations and include respect and ethical and reflective practice as one of the things. So that's the ECP that we hope to talk about. We hope to launch in the next couple of months through IMHA. Um, and that is really the coming together, in my mind, of the kind of aspiration that I would have loved to have as a care model for my mother.
Thank you, Kavita. Radhika, famous
Sure.
last words.
Yeah, I'll give a little short version and the long version. So the short version is please ask more questions and give more time. That's a short version to all the practitioners out there. The longer version is so if our goal is the better living condition of that person, that patient, if the carer runs out of steam, gives up, has their own breakdown, that goal is not going to be achieved. So somewhere you do have to just look out for the carer because they are caring for the patient, and if the carer becomes another patient, then that's gone. And so it's a question really back to you, is because all of y'all on this call, you have taken 2 hours out of your busy time, to listen to us. So you are so well intentioned and you want to already incorporate this. So just please reflect, what is holding you back from bringing on this carer expertise? Is it a sense of overwhelm? As it is, appointments are too short, the money, the finances are what they are. People won't pay more if you give more time. I know that. So is it overwhelm? Is it that it's not in your training? Because look, I'm just a layperson. Like, I didn't even know that you all had notes on describing a carer. That's why I reacted so strongly. That's why I've discovered that for the first time today here. Um, so it's not in the training? Is it overwhelm? Not thought about it? Is it something else? I think if we understand the reasons why you don't, is it a loss of control? Is it a questioning of authority? Is it something else? I think if we could understand that, then we could really engage well on building more holistic care practices that will help the patient and make you a successful mental health professional. Thank you.
Thank you, Radhika. And with that, I'm going to request the IMHA team to please bring the audience back into the room, and we can all be part of the collective again. And over the course of the last 90 minutes, we've had some questions and thoughts coming in. In the interest of time and keeping the discussion focused, I'm going to read out a few questions and club them thematically. And whichever of our audience or whichever of our panelists want to answer them can feel free to. But I think one of the most important questions that's come up today is, what are the best ways to collaborate with carers on a regular basis? Many tend to withdraw, thinking that they don't need to change their behavior. The professional needs to treat the patient. Some of them feel that they may not be relevant to the equation at all, or that their way of being involved may not be a significant factor bearing on the client's well-being. So whoever of the panelists would like to take this.
I'm happy to kick off. I think one of the challenges is that people, when you are talking to them one-on-one, they're also going through their caring journey and everything else that's going on in their lives, and sometimes they're in the middle of a crisis, and it can feel like that person is not is sort of pulling back or is not necessarily as interested in a partnership journey. But if we look at it at a cohort level, and which is what we talked about, can there be forums and frameworks and communities that mental health professionals can tap into? And I go back to the reference of, Bipolar India with Vijay, or a mission group with Amrit Bakshiji and others, and several forums like this, where you have multiple reference points. So it's not even, or the book Homecoming is an example. I hope it's only the start of a movement where you have multiple voices coming together. And then there is sort of a collective, there are certain trends that come up, there are certain patterns, there are certain standard similarities and also dissimilarities. So there is an ability to create a reflective space. And I think that's what it is. if carers don't feel alone in this journey of saying, first, I've sort of carried the burden of caring, and now I must carry the burden of educating my mental health professional partner about what I know, sometimes it can feel quite overwhelming for people individually. And it's also different depending on when we talk to people in the stage of their journey. So, people who are in the book, one of the things that we kept in mind is that let's make sure that we have people who have had enough time in their journey of recovery and healing and managing their mental health conditions to be able to have now a more neutral perspective on their relationship with their person with mental illness, as well as the relationship with their care providers. And we are able to, without being personally reactive, we are able to be able to give helpful inputs and nudges. I remember when I started off in this space, I was very impatient because there was so much I wanted to tell and so much I wanted to change. And I would constantly be telling everyone, what they can do differently, until I realized that's not necessarily as helpful, and people are deliberately not holding back. But it really is about, and so you would call it the I don't know, I suppose
Over-involved.
the over-involved carer now trying to overly influence mental health systems and service provisions. But really, there are a lot of enthusiastic people out there. So when we go around asking people how many want to be in the book, we could write 50 books like this, and there would still be enough people wanting to talk. So plenty of hands go up. We just need to know where to look. And plenty of people will want to spend the time and make the effort to have detailed conversations about what their learnings are, and they want to share. I think the question on this group really is, who is listening? Are we ready to listen and take in the inputs that are readily available to us today? And if we know where to seek them out, there are plenty of such opportunities. We can walk into any Al Anon room. People will be happy to have chai and stand outside and talk about every learning that they've had, and they can spend 3 hours doing it. So we have all the time in the world, and we are hoping that mental health professionals can find it as something that is a priority and an interest, and then be able to tap people at the right time in the right way. But the expertise exists, and the willingness to share that more than exists, is what I would say.
Neha, as you were speaking, I was scrolling up the chat, and Ms. Rita Seth has written that in Sambandh, we bring the person, the families are included in leading the organization. And we have a very good relationship with psychiatrists. And I'm wondering if you'd like to come in, Ms. Seth, and maybe just tell the audience a little bit about the organization and this perspective of collaboration, because it'll be great to hear from you, given that your organization actually focuses on carers.
Thank you. Thank you so much. So Sambandh actually started with the five families, families coming together, and one senior counselor from Sanjeevani Society for Mental Health, Vicky Rai, which I think is also on the forum today. And basically, we were at a stage when our parents were old, and we knew the responsibility was coming on to us, and we weren't sure we were prepared to handle it. Also, we had seen, our siblings and our parents live very compromised lives with no support systems. Medication was the only thing available. So there was one support group in Delhi called Roshni, where people used to meet. This was initiated by Dr. Nirmala Srinivasan, who who's worked for years in this field. And starting from there, we registered Sambandh Health Foundation to basically start family self-help groups. So we thought we'll have a lot of groups in Delhi and Gurgaon. That was our vision at that time. But within a year, the family started saying that we have the support system. What about people who actually have mental illness? So what can we do for them? And we started looking for, looking at various models. At that point of time in Delhi and NCR, it was very depressing to see the rehabilitation centers. Bangalore was slightly better, but then we came across a model in Canada where, the person was seen as a person and not as a patient. And that was, it was very beautiful to see that place. And we brought that model here. But the family self-help continued, I mean, We have families and members are the people who live with uh, who have a mental illness. They are incorporated at every level in the organization, including the interview panels of the most senior people, the director, the associate director. So people with a lived experience or families are always included on these panels because they are the ones who really understand uh, their own needs better than anybody else. And the framework we used, we adopted it from a Canadian framework, which was written by people with lived experience. And then we added the Indian context to it. So, starting from a center in Gurgaon city, we have now expanded our outreach teams go into 7 urban villages around Gurgaon, and we have a whole lot of community partnerships. So the program is cost effective because we have to do it free of cost, and collecting funds from mental health is not easy. And we were family caregivers who came together. I was 52 at that age when we started. uh,
And
uh,
could you maybe
this-
drop the link to your organization so others can also see
uh,
and
yeah, I'll just
maybe
do
the
that.
website? I know
Yeah.
that Vijay is here.
Yes.
The Mental Health
So
Support Foundation. I also see lots of others pitching in with their questions. And one of the very interesting reflection by Sarni Verma has just come in. And Kavita, I think this is something that you could take. That this whole question of lived experience as expertise, however scarcely acknowledged, is acknowledged only in the realm of legal adulthood. When it comes to children, what do we make of children's expertise, their agency? Parents as carers. It's a very completely different and very complicated landscape there. Any thoughts there? There was also a question about navigating consent during crisis and risk and suicidality, and what happens to
Hmm.
expertise there. So, if you'd like to take that, Kavita.
So, I mean, the short answer is it doesn't exist. We don't ask children um, at all. So we don't bring them into OPDs. We don't take the trouble of saying as a practitioner that if an adult has come to me or a mother or a father or somebody has come to me with mental illness, then I will bother to get the child in and ask them. It just does not exist as a concept. So we have to go beyond. It is aspirational. It needs to exist. It's a care gap.
Yeah.
That's definitely there. Do children notice? Of course they do, because I've also now in the last 25 to 30 years of my life, I've worked with children. One of the reasons I've worked with children is I think I'm still treating the little Kavita and helping the little Kavita who did not get this kind of help at that point in time. But it's flipped. The child comes in with the parent, and the child is the client or the so it's a very different way of sort of working, but involving the entire family and meaning making for the child is extremely important, because if you're looking at it in a zoomed out way, this child is going to grow up to be an adult who will need mental health work because of what has been amiss during the childhood and because of the lack of meaning making. And the other part of this that we refuse to sort of see is that just because society does not look at children and the impact on them doesn't mean that the impact isn't there and that they will not grow up and have an arc of impact. So I do think that aspirationally we need to involve children. There is no way we shouldn't. I think these boundaries of saying children need not be involved because they are children in this kind of a situation are artificial Western boundaries, because in the larger viewpoint, children are the most affected. Many of them end up being parentified children. This is also a Western concept that says parentified children. Uh, but imagine that nobody else is able to absorb the risk, but these children are absorbing the risk.
Yeah.
And over years, if a 12-year-old to a 17-year-old is absorbing the risk of a violent mother, imagine not just the trauma to them, but the kind of resources and resilience they would have figured out for themselves. And we're just sitting there and saying we first have to get someone to do a risk assessment. And many psychiatrists will feel that we can't do it because we are not trained, and many therapists will feel that. Here is this child who's been doing it for 6 years without doing a course on it. So I think those are our realities right now, and I think these artificial boundaries are quite colonized. So don't get me started. I do think that in our society, children and young adults are taking care of a lot of it. We refuse to recognize it and give it credibility, but we should.
Radhika, there's a question for you. What would be a good way to let queer clients know that it is a safe space for them to talk about their experience, apart from mentioning that our practice is queer affirmative?
I mean, I am going to toss it to Kavita at the end because I'm not a psychiatrist, but I will say, I think the answer depends. It's a little different depending if your client has come out to you or not. So let's assume the client has come out to you. Then I think as a mental health professional, your own experience with queer clients is important. So if you have any, you can say that. You can say, I have other gay, lesbian, trans, or bi clients. Just saying that I'm queer affirmative is that word doesn't mean anything. People sense trust on a very visceral level, and people sense shame, judgment, ignorance. Okay. So I just want to give one small example because it's funny. So I have a oncologist friend who's gay, and he's been with his longtime partner for maybe 15 years. So they're both men. The longtime partner is an executive coach. Again, another South Bombay story. So they're having some troubles in their relationship. So they go off to see a couples counselor in Bandra. But the couples counselor doesn't know anything about LGBTQ. So then they spend the session explaining what is LGBTQ. And at the end of the session, they say, respectfully, we're not going to ask you for payment for this learning session, but we're certainly not going to pay you for this couples counseling session. That did not happen. Okay. So I think if for you to actually be a safe space, you have to have some proximity with queer people. You have to have some experience. Other clients is fine. Doesn't have to be yourself. Doesn't have to be in your family or your friends group. But I think having some proximate knowledge is important. If you don't, there is queer theory that can be read. Okay. And now, if your client has not come out to you, but you suspect that they are queer and that has an issue in their mental health, then I'm going to toss that one to Kavita because I don't know the answer.
Well, I think you've answered the question. I mean, you treat them just like anyone else. You treat them with respect and with curiosity rather than with any kind of your own judgment. Two questions there. One is when somebody is queer, this is not a mental health issue. Yeah, so that has to be very clear. This is not a mental health or mental illness or a this is nature. If somebody has given you the honor as a practitioner of revealing their sexual orientation in today's world and context, then they have chosen to trust you with something that they may not trust everyone with. So it is not about what you're going to do. It is about seeing that they have actually trusted you with who they are. Now it's up to you to respond with the same kind of authenticity to be able to establish that trust. If you don't know
Ask.
how to be
Ask the
queer,
queer person. The
yeah,
queer person will also have resources. They will
yes,
guide you to books and
bil-
literature that
bilkul.
explains the
Ask
experience.
them, go back and ask your colleagues, somebody who is queer affirmative. There are queer affirmative courses. The Mariwala Health Initiative has actually taken out a book for last year for therapy. All of those things are today present. So basically, reflect, make yourself aware, and make sure that you know what to do besides being
If you
respectful.
don't, I think don't pretend because a queer client, like we're
Yeah,
too quick at figuring it out. Yeah.
yeah,
Like if you're bullshitting, we'll just know it like very fast.
yeah. And that comes from actually reading micro expressions for years because if you remember, then sexual orientation and gender identity, before coming out to someone, you first have to read whether they are going to be safe for you or not. So somebody who's queer has read safety over and over and over and over again, sometimes read it wrong and therefore corrected themselves. So the amount of honing of that skill, it's immense. So if they've chosen to say to you that I am coming out to you, they have actually said, I'm putting my trust in you. This is a huge privilege. And they have actually said then that with all this skill that I have gathered of judgment, you're okay. I'm okay to come out to you. And that in itself is a badge of honor, according to
I
me. So
agree.
if a young
I
person
agree.
actually comes out to me, I'm like, wow, thank you. Thank you for trusting me. And I think that immediately changes the equation. So I would say that is my primary this thing: respect the person and where they're situated, where they're located, what they're doing, and that this is a privilege that they're sharing with you. The other part of the question is if there is a mental health comorbidity or an illness alongside someone who is identifying as queer, that what is the difference in treating? There is only one difference in treating. You still have to treat the mental illness in any way that you will treat anybody else. It is not in treating the mental illness that there is a difference. It is in treating the person and how you hold them in your mind and how you separate their identity from the illness and treat the illness. That is what is key, to actually say that just because I am a queer mentally ill person versus a non-queer heterosexual mentally ill person, my mental illness does not change. What does change is that the likelihood that this person has come in with a lot more trauma behind him is very high.
Yeah,
The
almost
emotional
guaranteed.
history,
Almost
yeah.
guaranteed.
It's 95% guaranteed that they have had every kind of bullying, microaggression, micro trauma, all kinds of trauma, and they're carrying that even if they don't have PTSD in the way that psychiatry recognizes it. That difference you have to. So the personhood of that person, that they will be wary. They are trusting you, they will be wary. They have probably read up about themselves. There's a 80% higher chance that they've actually figured out things before coming to you because they know that they're not going to get the right this thing. So making sure that you're bending over backwards rather than asking them to bend over backwards, because prior to coming into that room they have gone through a period of persuading themselves and getting over the stigma and the shame and the perceived trauma before coming to you. So that is
I
the
just
difference of what they are carrying in. That's
Can
And
I just
I'll just
add to
add
that?
here that there is a real demand for this, okay? I get, like, I'm telling you, a person a week or at least a person a month asks me, and I don't know where to send them. So, if as a request to IMHA, I think if you can have some sort of self-selected group that wants queer clients, there's plenty of queer clients in India needing mental health therapy more than psychiatry. And the second thing is, please, as mental health professionals, please be honest with yourself. Like, if you're not comfortable or not knowledgeable, then just don't take those clients. It's okay. Don't do it. It's okay. We'll find someone else.
And Radhika, thank you for that last nudge. Bakul, if I may just expand on this particular question was for the queer population, but actually the answers that Radhika and Kavita both gave apply to everybody, right? Everyone is looking for a sense of safety. Everyone is looking for not being judged, of being seen as a person, not as a patient, of being that gaze that doesn't leave the paper and pen, and while the person is sitting there worried about and when you look up at the clock. Everybody who's a carer and a PMI person with mental illness who is been in any of those rooms notices all these things. So I think it really is about that recognizing and seeing that whole self. And may I say then that the best way to do it actually is what Radhika said last, is one is to be honest with ourselves, but the other is to be able to try and own that honesty and hold that reflection and realization at least within ourselves, even if it is not disclosed in a session. But let us not forget our humanity, let us not forget our own experiences when we step in to do a session, because that really is the game changer. I can tell you within 3 minutes or 1 minute of talking to a mental health professional, and I must have been in and out of at least 20 inpatient facilities, maybe 40 50 psychiatrists on the personal front, same number of therapists, not the ones we work with, but the ones we've been through for our family. And in 2 minutes you can tell whether this person is someone you can relate to, you can trust, you can understand. Of course you build on it over time, but essentially, cutting through any kind of posturing, pretense, hierarchy, all of that is really important. The number one gift, therefore, that everyone can give their potential clients is to really be their whole selves. Maybe not in disclosure, but at least in terms of where you're coming from. Because I would pick a practitioner with lived experience any day over a practitioner who's reading off a book, and even if they have 30 years of experience. But I would pick people who have been through it, who understand the in-betweens and the invisible bits any day. And I think everyone finds that that is really what provides comfort, trust, and safety. You will forgive somebody, a practitioner who is perhaps taking their time to get to the right dosage because they're trying to be careful and thoughtful about it. A practitioner who may have experimented to some measure, all of that. There is much more forgiveness in a client practitioner relationship if there is the trust, knowing that this person at least understands what my felt experience is. So knowing and owning our own lived experiences as practitioners, and many people have that, is really the biggest gift one can of course give to oneself, because it just means that you can just be yourself and be honest about that. But really it's also about what people will value the most, those who are sitting across the table.
Thanks, Neha. We're going to take one last question now, and it's a really beautiful question that Soma has just posted. And she said, without judging the practitioners, is it possible professionally to help over-involved caregivers give themselves a rest or break? I think in clinical parlance, it's called respite or, you know, but it's a very real question. We can't talk about caring without talking about the emotional toll that it takes on people. And really, it's not just a toll. I think it's fundamentally, I think it sears through you. So, just from your lived experience of how you've managed to give yourself a rest or break, if at all, anything.
Uh, I'll go on with a funny anecdote as usual. So, in my attempts to sort of maintain some energy and resilience through this caregiving process, so I've also tried Reiki healing, right, in addition to visiting a psychiatrist and a therapist. And so my Reiki healer told me like a month ago that I am exhausted and that I should take a rest. And I just looked at her like, on what planet are you on? That is not going to happen. But the note was helpful. So I think to the more serious answer to the question is, I think it is always welcome feedback from mental health practitioners to just like how we, like as carers, can tell when the eyes of our family member is, I mean, the eyes is a giveaway every time for oncoming mania or psychosis or whatever. But just like we can judge for our relatives, probably a caring, engaged mental health practitioner can judge for us. So if we are close to burnout, certainly somebody needs to tell us and we will heed the advice, is how I say it. So I made a joke of what the Reiki healer told me, but I did think about it. Like,
Yeah. I think what I'd say to that is that when mental health professionals tell you that you need to back off, slow down, I think it's really important to listen before giving that advice, because often then the journey, the struggles, the bigness of what the carer is going through seems to be minimized and abandoned. It's just negated. So I feel like it's helpful to give that input that take it easy, slow down. But if you just do it without actually listening to how that person is feeling in that moment, and even if they're wound up and charged up, giving it their due space and then being able to reflect on that is really helpful for people to sort of wind down. And the other thing in terms of sort of the caring journey for oneself is different at different ages. So I know the most restful thing that I did as a young person dealing with a parent's absence, schizophrenia, and all of the absence and all of that, was just running. I played hockey, I played badminton, I played. So just to say that, kids deal with it differently, and sport really literally saved my life. I ran from my troubles. It was the best thing that I could have done for myself until I grew up and found the mental, physical, and social resources to be able to access a bit more structured care. So care can look very different. Exercise and doing things for oneself, especially communities, a sense of being and belonging, which is literally the name of my chapter in the book, is really for me very, very key. People to share your misery with is a gift and a fortune. And friends here also who have that, it's a real blessing. So that's what I'd end with. Thanks, Bakul.
Thanks, Neha. Kavita?
So I'd say two things here. One is that oftentimes why a carer can't take a break is because they have been with the person so often and so well attuned in such a well attuned way that they understand that nobody except them knows how to pick certain things up, escalate them, and take
Yeah.
care. So it is extremely difficult for that carer, the over-involved carer, to believe that anybody else could actually do it as well as they could, which means if they take a break away from the person with, then something bad can easily happen and nobody will pick it up. And then they would have to deal with the guilt of that, which is an ongoing guilt. So the reason many people are unable to take the break is not because they don't wish to or they don't recognize that they're burnt out, because most of the parents who come to me or most of the people who have been doing chronic illness caring know that they are burnt out, and they know that they have been on survival and low energy mode and conservation of energy mode for a very long time, that they have put away large sections of their lives because they just cannot even aspire to look at the energy that they may have. So given that that is the situation, it is not about taking a break. It is about saying, is there anybody else who could, even for a short period of time, step in with enough of safety? And is there somebody who can tell me you are not to blame? That although you are the primary carer, is there somebody like this professional who will say it's okay if your person gets 60% of the care for 3 days, rather than 120% attuned care every day, because man, you are going to burn out and then they're going to get no care, but also your own life, you're going to start resenting them. So for a professional, it is so important to acknowledge and say, this is the work you are doing. You're not invisible. You're doing more work often in living your life and being a carer and possibly a provider and possibly a mother or a daughter or whatever else. So I think the acknowledgement from the professional is extremely important, and building up an ecosystem of respite and support is also extremely important, as much as forgiving yourself that you became this person because there was no one else. That is why you are 120% attuned. And even if there are days when somebody is 30% attuned, it's all right. It's okay. There was a time that you were 30% attuned 3 years ago. So I would offer to Shoma and every other person who's there that please be aware and acknowledge the baggage you carry, and it's okay. It's okay to sometimes shed. I don't know if that's helpful, but there.
Thank you, Kavita. I think that's a really beautiful, profound note to be ending on.
Yeah,
And
okay.
please see the love that's coming your way on chat, the takeaways that people are sharing. Tons of quotable quotes from this session. Thank you so much to all the panelists. Thank you very much to the audience. What an engaged audience, and very moving sharings. And I do hope that all of you will reach out and access the book Homecoming, and we'll keep you posted about our upcoming programs. And lived experience will always be at the center of everything that we do. So hope to see all of you in everything else that we do.